Hello, everybody. Welcome to the first in a series where we are going to be interviewing different healthcare people. If we've never met, I'm Liz. I am a family nurse practitioner, and I have my special guest, Roxy, here today. She's going to introduce herself in just a minute. She is a interventional radiology nurse practitioner, and I know almost nothing about the topic, and I didn't look anything up. So this is going to be a learning experience for both of us. I kind of thought about preparing, and I was like, I should look it up so I'm like a really good interviewer. And I was like, no, I should go in like just as I am. So I'm asking the questions that hopefully other people have. At least that's how I justified my laziness. So I have asked a lot of you questions over on Instagram about questions you had and then questions I have. The whole point of this series is just going to be to get to know different professions and different facets of it, because school really kind of puts you in this lane of like, you know, when you go to nursing school, you are going to work on the bedside and you're going to work in med surg or deliver babies. And then when you go to NP school, you're going to be in primary care or pediatric, you know, like it just siphons you. So this is just to kind of open up our eyes to like the different awesome professions that there are, and answer your questions about them so we can understand them a little bit more. So thank you, Roxy, for being our guinea pig. This is our first, actually, we did a NICU one, but that one was kind of unofficial. So this is our first official welcome. Would you like to introduce yourself and just say hey and kind of what I already said?
So I am Roxy. I'm a interventional radiology nurse practitioner. I was previously a nurse for about 9 years before that. So I have experience in cardiac step down, neurotrauma ICU, and in the last 4 years before my NP job, I was an IR nurse, which
Awesome.
Actually I went into that job interview exactly as you were. And I said, I have no idea what this is.
Were you like, oh, this is days, I'll take that. Let's apply.
Do you have any procedure experience? I'm like, some bedside ones. So I did work, but
That's awesome.
I did complete a family nurse practitioner program at Oakland University in Michigan. I graduated in 2020. So obviously you get prepared to be a primary care nurse practitioner.
Yeah.
The jobs that are related to that scope of practice. But actually working in IR as a nurse, I really loved the environment. I love it's procedural based. So you get to see a lot of very cool things that we get to do that are minimally invasive. So we save people a trip to the OR. In very many cases, we usually can do our procedures without anesthesia. So it saves them in that regard too, with the ability them not having to pay for that. A lot of our procedures are actually just local anesthetics like lidocaine or conscious sedation. And our nurses administer conscious sedation. They're trained to do that.
Oh, sweet. So I didn't even know that you could be, I thought you would have to be unconscious for it. My background is like med surg and then peds. And so obviously our kids, I mean, they couldn't be awake. And I feel like our livers usually were asleep, but that was a while ago. And maybe that would be hardcore if you're awake. So good for those people. Could you go for it?
Sometimes it's hard to convince patients that they can be awake and get through the first part.
And I feel like liver people are, when they're at the, not liver people, that sounds bad. Patients who are undergoing a liver IR procedure are usually kind of confused at that point. And we got called down a lot and they're like, they need a little bit more of this. And we're like, okay. Could you just give us a brief overview of like, what is interventional radiology for the people like me who send people down to IR, but we don't have really much of any clue of what happens there?
Sure. So interventional radiology, we do procedures that are image based. We use imaging for guidance, basically. That includes fluoroscopy, which are live X-rays, ultrasound guidance, and CAT scan guidance. So those are actually the main modalities. And depending on what we're doing, biopsies or whatever, sometimes they can be completed in different modalities, actually. So for a patient that has, for example, a pleural effusion, we can do a thoracentesis on them. That is a very quick procedure. Basically, we use ultrasound guidance. If they have a large effusion, you can see it. It saves them on radiation. And it's minimally invasive. We numb up the skin. We use lidocaine. We go in the back. It takes about 10 minutes to drain them. sometimes when you're imaging with ultrasound, you notice that the collection is actually not a simple effusion. It looks more like an empyema. In that case, we, depending on how it looks, we may actually transition them to CAT scan if we need to be more precise. So sometimes we start out in one modality and we end up transferring them to another department where we can do the procedure more safely. What I love to do ahead of time is look at all the imaging that's available on all of our
Mhm.
procedures, because I can basically figure out where this patient needs to go, and it saves us a lot of time when you can see is, for example, I'm using pleural effusion, but is it simple? Is it loculated? What is their clinical background? Is their white count super elevated? Do they have pneumonia? Is it pneumonic effusion? There's so many different things that it could be related to. Can it be
Yeah,
related to cancer? Are there, um, do they have tumors or anything like that? History of cancer. There's a lot we can even do with that fluid. We send it for testing. We can see if it's infected. We can see if there's cancer cells, all that stuff in there. So
that's
even with the
awesome.
simple, yeah, even with the simple, just they have a pleural effusion, we can see it on x-ray, we can see it on ultrasound, CAT scan, and it looks different in all these different modalities, and really you can get different types of information from all of them. So I like to look at previous imaging. I like to see if we've done procedures before. Sometimes actually they'll order things like a thoracentesis, and this patient actually doesn't need that.
Mhm.
They had it priorly done, the cytology was positive, it's going to be a recurrence, going to keep coming back. We risk basically collapsing their lung every time we do this procedure. We talk about risks are bleeding, infection, pneumothorax. If we keep poking them every single time, it increases your chance
Yeah.
to have, basically on the underside of the ribs, run your artery, vein, and your nerve. So you need to be careful of how you're pointing that needle and to avoid that. So actually, sometimes me getting the background helps us in talking to the other services and saying, hey, this patient actually needs a Plerex catheter, which is basically, it's also done under minimal sedation. We just usually use local anesthesia like lidocaine, and it feels
Mhm.
about the same as a thoracentesis. Takes about 20 minutes, and we place a drain into the pleural cavity. It gets tunneled through their skin, and then they have access where they can drain at home.
Oh, that's nice.
So
Yeah.
part of my job is deciding, even though we got consulted for this, we have to, critically think. And that comes with
Mm.
just, seeing the same things over and over, seeing the different effusions, and it's just basically through experience to get better at figuring out what the patient needs.
Yeah. So that kind of goes into a lot of people were wondering, like, what does your day to day look like? And it looks like a lot of it is either, procedure based or like looking at everything that they sent you and then deciding, like, is this actually appropriate? What would be better? And kind of going based on that. Could you walk us through kind of like what a typical day looks like? Or do they look different? Do you have procedure days and then clinic days, or what does that kind of look like?
So different IRs function differently, but the way ours is we have one interventional radiologist and there's one uh, NP, me. So what I do when I come in actually is I look through the list. We have outpatients and inpatients that get added. We have to do a history and physical on all these patients, even though it's just like they're coming in for a procedure. You still
Yeah.
have, that's
Yeah.
that's probably the one thing from NP school that actually was helpful. Like, oh, I can. So I look up all the patients, look up their imaging, uh, basically see what needs to be done first. Do we need to be NPO for the procedure? Are there coags basically within a safe parameter to do the procedure? And
Mhm.
for low risk versus high risk procedures, we'll take more chances depending on where we go in the body. We can deal with a higher INR, and we're not so worried about bleeding complications. So again, that goes back to experience. You
Mhm.
tend to figure out what you can get away with, and even though we have guidelines, sometimes you take risks depending on
Yeah.
how. So anyway, the first hour is just me getting all the background information, looking at how much imaging I can, holding blood thinners if I can, talking to the other services, correcting INRs, all that stuff. My job is not only procedural, although I do several types of procedures. I do paracentesis, thoracentesis, So that's basically draining ascites for your
Mhm.
liver patients.
Mhm. Yep.
Who have portal hypertension, and then they
Oh,
develop
yes.
disease. And I see a lot of the same liver cirrhosis patients. I've done some of the same ones. I don't know how many times, but thoracentesis, lumbar punctures, bone marrow biopsies, pleural drains, nephrostomy tube exchanges, suturing. There's a lot that you can do,
That's
and
awesome.
actually, depending on the IR, some PAs and NPs do even more than like they'll place metaports.
Oh,
Um, so in our and they'll do dialysis access. Oh, did I say PIC lines? PIC lines, I place those
no.
as
Oh, yeah, we do. They do PIC lines, don't they?
yeah. So
And is that kind of dependent on like what your the other people in the IR are either comfortable like teaching you how to do, or is it like a formal training that is there any like additional training that you did that was kind of like by education, like a certificate that you did, or was it just like, hey, you worked here and now I'm gonna show you how to do this?
yep, that's exactly it.
Yeah. Yeah.
He trained me on all the procedures, but then obviously you need to revisit anatomy a lot
Yeah.
more.
Yes.
Every time you approach somebody, even though you do the same procedure, everybody's anatomy is different. You have to know the risks. You have to know the anatomy. You have to be careful every time going. um,
Yeah. That's awesome though. So it sounds like it's super procedure heavy. So if you don't love procedures, this is not your place. Like I would not like this I like to talk to you human, but don't make me touch anything sharp.
I
um,
love, yeah. You
yeah,
have to love procedures, and you have to love like getting your hands like in things. And yes, you do.
you're like,
Like
yes, you
for
need to
bone
do
marrow
that.
biopsies, you're drilling into somebody's hip bone. Like
Yes, that
you have
sounds
to be
just,
comfortable with. And
yeah.
basically, we're doing the posterior iliac crest. You have to look at the SI joint and make sure that your needle's not going you
Yeah.
know, wherever you don't want it to go, and then you're causing damage to somebody. So
Yeah. See, I'm so glad there are people like you that like live on that, because I would be like that's my nightmare of a day. I'm like people come in even for like a little incision and drainage. I'm like, couldn't you go to urgent care? Like, couldn't you have them do that for you?
um,
um,
so it's
what?
not procedural though.
Okay.
Uh, it is also, we're a referral business. We do also make money on consults. So that's
Mm-hmm.
something a radiologist doesn't have any time for. That's another part of my job, is going and rounding on patients. So we'll do consults on the patients that we're not doing procedures on the same day, because you can't bill for a procedure and a consult same day.
Oh, yeah. Yeah. That's a good point.
So for the people we're not doing that day, I'll go up, I'll do our consult, and then if we're placing a drain or if we're doing something that needs follow up, it's also me going up and rounding on the patients afterwards. So there's that aspect too. There's the clinical part, there's the rounding, it's not just procedures. So you get a bit,
Yeah. You do get to talk to people occasionally,
yeah.
not just stab them. That sounds good. What so it sounds like it's based in a hospital, which makes sense because I feel like that's where most of the procedures are going to be. What does that mean your schedule looks like? I mean, I'm sure that varies kind of based on what IR, how big your hospital is. Are you there on the weekends, or is it like days mostly, or what does that kind of look like?
So I am salary based. I'm Monday through Friday. It's supposed to be 8 hours a day, but never is
Yeah.
in the
Yeah.
hospital. I don't do weekends, holidays. I don't take call.
Oh,
Some
sweet.
IRs do, like the PAs and NPs do. So you have to
Mhm.
really basically ask if you're interested in
Yeah.
what
Yeah.
what their expectation is of you. Also, you have to, depending on the state you're in, you cannot operate fluoroscopy as an NP
Interesting.
or PA in certain states. So before you do something like that, you have to check the state guidelines. In Michigan, obviously, you can.
Yeah. And I think depending on where you work, how small the department is, this is something I found as an NP was the people you work with don't necessarily know those guidelines. So you have to look it up, like, cause when I worked as in primary care, like my collaborating physician, she had no idea what I could and couldn't do. She was like, oh yeah. I'm like, no, I can't do that though. And she was like, oh, so I imagine that would be important if you got hired like at a small hospital or something, and they were just expanding their IR department or something to know what can you and can't you do, so that you're finding out like on the front end and not the back. is there anything else that you cannot do that like a PA could do or a physician could do? Where does that line kind of go in terms of scope of practice?
So scope of practice, PAs and NPs are basically interchangeable. I don't think there's
Okay.
anything a PA can do that I cannot. There
Mhm.
is actually something called an interventional radiology PA. I don't know much about that field, but apparently I think some of them read or pre-read or something x-rays too. So I think they have additional training. I think
Mhm.
those versus regular PAs maybe can do some more things that I cannot. But in general, PAs and NPs, depending on the IR, they'll train both in the same
Mhm.
types of procedures that they want you to do. A physician, a radiologist can do a heck of a lot more than us, and actually, not even every interventional radiologist can do all the procedures that that the next one can. So, for example, we had one that did neuro procedures, and he did more like the LESIs, the lumbar punctures. He did the kyphoplasties. Our
Mhm.
regular interventionalist had to pick up once that one left the LESIs, the lumbar punctures, but he doesn't do kyphoplasties, or at least not yet. But he does
Mhm.
like Y90 procedures, or he does a lot of procedures for patients that have like uh, cancers that have metastasized to the liver that are unresectable. He'll do local regional therapies. So it could be
Oh.
Y90, which is a radioembolization. He could do chemoembolization, bland beads, and that all depends on the patient's liver function and all that stuff, because all of those procedures carry risk. Depending on
Mhm.
their size, he can do things like ablations. He can do, depending on the organ, you can either do cryoablation versus using heat. So there's a lot that he can do. I
Yeah.
will never
Yeah.
do, and I don't want to do, to be honest with you.
Yeah. Yeah.
Oh,
And do you ever get to go in and like on some of the stuff that you wouldn't do independently, like an assist to get to kind of watch it? Or is it usually like a one person thing?
so he can do ours can do everything on his own. Like he's
Yeah.
but anything that I wanted to participate in or wanted to see, he's definitely let me do it.
Oh, that's cool.
We have IR techs that are
Hmm.
specifically trained in every single procedure to know how to set it up, what tools he's going to need throughout. They're with him all the time. But I've subbed in on cases for them, especially if they were, busy or whatever, or short
Hmm.
staff. And it's pretty cool. It's pretty fun.
Yeah.
And if you're like holding like the equipment, but he's even let me deploy like IBC filter and stuff. So you get to do.
And then so that's awesome. It sounds like kind of like the OR in that way where like you can kind of get brought in and they're like, oh yeah, but you can come like, you can hang out with us for this. And you're like, ooh, I'm so fancy.
Yeah,
What
scrub
one
in.
thing a lot of people wondered was, is the IR like the OR? They sound very similar. Are they the same or not so much?
I don't think so much. The only OR experience I have is from nursing school, from getting to shadow a couple times. But I think it's a lot less stressful because we have a
Mm-hmm.
close knit small team that works together all the time. It's not like a whole bunch of physicians and a whole bunch of different staff, and
Mm-hmm.
I think it's a lot less hectic. It's I think a lot less organized. Everyone that comes to IR thinks that they have a specific time when we're going to do a procedure, but we don't run like the OR that have specific times. Like, oh, you have to be here at 8 or 10 or 12. We basically just fit people as we can, and when we get emergencies,
Mm-hmm.
so it's different structurally. It's obviously you're still using sterile technique, you're still gowning up, you still have like don't touch the blue table or whatever. You're
Yeah.
not
Yeah.
sterile, but I don't think it's the same as the OR.
Is like that.
There's some
Yeah.
similarities, I guess.
Yeah, but like overall very different. Like the OR is in the OR, even if you're using a Da Vinci or like laparoscopy, it's just going to be so much more. I think like you said, the close-knit unit, because when I think of the OR, there's just so many
Mhm.
moving parts and you don't necessarily know who it is because there's just, they're scrubbing through. What does the room look like? Like, does it look like an OR? Because when I imagine IR, I have always imagined, which is very unrealistic, sending my patients down to like a black room that is just like black I don't know why. And then everyone's standing in there with their gowns and it's like really dark, except for the light of, I don't even know why I imagine that, but I've always imagined it that way. Like,
So there's a
I guess
YouTuber
because radiologists usually live in like little,
in the dark.
hidden away.
They do rooms, but not in our procedure room. So they're
Makes
actually
sense.
there's an interventional radiologist, Dr. Cellini, on YouTube. And if you really want to see what an IR looks like, he takes videos, he
Oh,
documents his
sweet.
IR journey. So that's who I would point you to.
I'll leave
But
it linked below. That's awesome.
I mean, there's our fluoro table, and there's probably a whole lot less equipment in our IR room than there would be in an OR.
Mm-hmm.
Again, I would have you just look up his video. You'll get a very clear picture, and you
It's
can
going to burst my bubble, my 10-year bubble of thinking it's like a black tent in the basement.
And the thing is, like I said, not all of our procedures are in the IR room. A lot of them use ultrasound or CAT scan, so we'll go to those departments, or sometimes we'll go in our whole room, or we're just using a bedside ultrasound machine.
Yeah.
So
you're going to burst my bubble here. This is like since I was a baby nurse, this is how I thought of it. What would you say on a scale of 1 to 10 that the stress, like the average stress level is? Like 1 being I work at a flu clinic and 10 being, CVICU, something hardcore, the ER stress.
So I think the stress, and I'm actually about to hit 1 year here and I don't know, 3 weeks or so. The stress is in not knowing imaging, because in NP school and your primary care NP program, you get very little of imaging. And this job basically depends on what does imaging show. So you have to basically do a lot of learning at school. You have to basically I bought a lot of books, bedside ultrasound procedure book, a CAT scan, intro to CAT scan, intro to radiology, and chest x-ray book. I bought the themes anatomy book. Basically, you have to teach yourself. You have to review the imaging with the doctor, and slowly you start seeing things like on CAT scan. Now I know if someone has hydronephrosis, if they have stents, if their ureter is enlarged, if they have a stone, like where is it, and is it in the ureter, is it in the kidney, is it in the bladder? Do they need a procedure from us? I can start picking things out like that, looking at things like liver masses, or sometimes things look like liver masses and they're not. It's a hemangioma or whatever. So there's a lot of different types of imaging they do to figure that out, and it's just it takes some time getting used to the imaging. That's very stressful, because we will have sometimes over 20 cases in a day where you are responsible to look up these patients. You have to, like I said, you have to be on PO. Do we need to hold off blood thinners, all that stuff? And then what is imaging showed? Is this a procedure done right away? Is this something that could be delayed? The stress of not knowing all that information, and the better you get at it, the better you get at imaging, it becomes pretty routine.
Okay. So initially, yes. And then it kind of comes down, because now I was almost about to say, like, you could just send it to radiology and be like, let me see the impression. I'm like, oh wait, you are radiology. Like, this is actually your problem. And we appreciate you, because I don't know how you read those things. It's very impressive. So you anticipate kind of going forward that it will not be an insanely stressful, like, adrenaline career?
I think that once you get the fundamentals down, and once you've seen something, like you see the same things over and over, that it becomes like, for example, I've been there less than a year. I've done probably over 400 paracentesis procedures alone.
That's awesome.
So you get very good at looking at ultrasound, look at the CAT scan. Do they have a large or a small amount of ascites? Is this complex versus simple? Is it you just get really good, because you repeat the same things over and over. So the stress level, it's significantly lower than before, because before I had to learn the procedures, the imaging. How do you write a consult note? Like on
like how do I even document this? Yeah, let alone do it. Yeah.
You learn how to write a note in an office. It's not the same inpatient. I'm like,
Mhm.
I was kind of upset because they didn't let us actually do clinicals on in the hospital like at all. So even though I had a couple sites that were willing to take me, I couldn't do them, and that would have been just
Oh,
so beneficial
yeah.
to
Oh, yeah.
skills in my career. So that's we won't get into that, but
Yeah.
that would have
Do
been helpful.
they Yeah. Do they ever hire acute care NPs to do that? Or do they seem to prefer adult or like, what about adult Gero?
I think it. I don't know if it matters so much if you're an acute or primary care program for this type of job because they're not going to teach you these
That.
procedures in any of
Mhm.
those
Yeah.
programs. I think what you might get in an acute care NP that would be more beneficial is obviously you'll see inpatients, you'll see how they round, you'll see how they do their consult notes. And a lot of times I think they teach you maybe some paras or thoras or putting in some,
Mhm.
so
Yep.
you'll get some of that experience. So yes, if you want to stay in the hospital and you want to do this, it would have been more beneficial to get my acute care NP. But if I didn't get this job, I don't think I wanted to do ICU critical care. I did that as a nurse. I
Mhm.
didn't see myself doing that as an NP. So primary care, the one good thing about it is that it's got such a
Yep.
general scope that you can
Yeah.
basically put yourself anywhere if they're willing to take
Mhm.
you.
Yeah. If they're willing to teach you, yeah, you can really go anywhere, which is for at least most places that are outpatient or in between. It seems like FNPs can kind of go to like you did, like the IR, like cardiac in between land, whereas it's harder for acute to necessarily step out and do primary or like outpatient type stuff. What do you think would be, other than being an IR nurse, what kind of background would really help you if this is something you are interested in as an NP?
Uh, honestly, probably having critical care experience, because they do things like central lines. They do some of the bedside procedures,
Mm-hmm.
like maybe a para or a thora. They do see inpatients. They round on them. Then they do consult notes. So that kind of experience is going to make for an easier transition into this type of job. Having
Mm-hmm.
an IR nurse experience and working with the physician that you're going to be working with as an NP is like the perfect.
Yeah. Yeah.
You already know how he likes to do things. You've already seen the same types of cases over and over, so it's a little bit easier, I think.
Mm-hmm. Yeah.
But
And someone had asked, oh, go for it.
no, no, girl, go ahead.
Someone had asked specifically if they were an OR nurse now, should they try to switch to like, they had asked to switch to IR. And I think it sounds like the recommendation would be yes. I mean, I think there would be probably some crossover of like, okay, this is much more procedurally based, like, but you wouldn't really be reading imaging, you wouldn't have, and depending on what kind of OR you were rotating through, you might not even see, you'd be doing a bunch of open type things and not even laparoscopic type things, which I would imagine maybe would transfer better. Um,
Are you talking about an OR like an NP OR, like a first
as a
assist?
nurse, if you were working in an OR as a nurse, like, should you really try to scoot your booty over to like IR and get
I,
a job in as a nurse to become an IRNP?
yes,
Yes.
definitely.
Just do that. That sounds like an excellent blanket statement. You're like, yes,
If
just,
you're a nurse and you want to get into IR as an NP, get yourself an IR job as a nurse because things will just go so much easier for you. And then not only will you have the background and understand or start understanding the procedures and maybe why we do them, but you also can network.
yeah. Yeah. And just kind of finagle yourself into the job and be like, wouldn't it be so nice if there were just two of you and you could just,
That's what I.
hi. Yeah. Yeah. That is a excellent way to get a job, is just to kind of create one and be like, do you know what I could do for you? Like, and use money, because they can do more procedures. They
Exactly.
can be in there doing more stuff if you're off rounding.
I think a Y90 costs somewhere about like $130,000. So if
Yeah.
he's doing paras thoras, that I think maybe they make 1,000, maybe up to 1,800, something like that per procedure. Not that we get all that revenue. I don't know where it goes.
Yeah.
Me doing those cases, those small cases where he doesn't have to worry about them, he can take his time doing these procedures, doing these angiograms. Even with like GI bleed patients, we usually can coil off arteries to where they don't need to go to the OR. And it's just a minimally invasive procedure where we
Yeah.
puncture an artery, take our catheter up, inject dye. And if we see an artery that's bleeding, just place some coils in and stop it that way.
That's
So
awesome. I listened to a podcast recently that made it sound, they were doing like gynecologic IR type of stuff. And they were making it sound like, I mean, that field is just like exploding, like into all sorts of different things.
yep, exactly. Even for things like uterine fibroids,
That's what
basically,
what it was. It was fibroids.
instead of them doing the doing a hysterectomy, basically, which is a surgical procedure, has complications, we'll do something called an uterine fibroid embolization, and he has started doing those more and more often. Obviously, you have GYN that's going to hold on to their cases and not necessarily talk to patients about it, but usually if patients hear about this option, they're more gung-ho for doing something minimally invasive. The only caveat is for UFEs, you need to be done having kids. Like, you need to not think that having kids in the future, because you may not be able to bring them to term afterwards, or you might need C-sections or whatever. And there's documented cases where they've successfully had kids after this procedure, but it's something you want to be done with before.
Yeah. That's interesting. I never even thought of like the potential animosity between someone who would like, it would be in their best interest to like kind of not tell you. That's interesting. Also, I'm like
prostates too, but then urology, we'd be taking their cases.
Yeah, that's interesting. That is very interesting. I'm also very jealous of, it's just so funny. Like, one of my things that I get annoyed about is like how much primary care is paid for procedures or like anything compared to like IR or specialties. Cause I feel like we, do something, we could like do some complicated biopsy removal and like sew people up. And they're like, here's $80. And you're like, thank you. Glad I spent an hour doing that. Yeah. I was like, oh, $1,000. That's fine. Like, it's like half my day. That's awesome.
Yeah. And again, I don't know how much, we don't do the billing side, so I don't know how much we actually, I just know patients will be billed like several $100s to like 1,800, and me just looking up how much they cost.
Oh yeah. No, that's been,
maybe we have to get $80. I don't
yeah,
know.
I hope not. It's a mess. I worked at a really small office, so I got to actually see, I had to bill. And so that has been eye-opening, because I'm like, this is just such a mess. Like, all of this is backwards, but we won't make you talk about that because that's a whole different episode. What is your favorite thing about IR, and then your least favorite thing about IR?
Okay, well, everybody already knows. My favorite is procedures. There's literally, I don't think there's a better feeling in the world when you get a case done and you do it in a way where a patient barely even feels anything. And a lot of these patients, when we're draining them, they can breathe better, they feel better. And when we do it in a way where it's almost no discomfort at all, or even things like a bone marrow biopsy, they come in with scary stories of the office and they're scared to death. And then I do their bone marrow biopsy and they're like, oh, that was it.
Yeah.
Numb up their bone with lidocaine. Like, it wasn't even anything else. So the satisfaction you get from that, like, honestly you just can't compare it to anything. It's amazing. Love it. So procedures are my favorite thing. I love that we can do things for patients, therapies, or get their biopsies done, and we do it in a way where it's really not very painful. We can get them through it pretty easily. My worst thing, I don't so much love doing consults. It's a lot of writing.
Why ever not?
So again, with billing, you have to make sure all the things are in there. Sometimes we'll do a simple or a really quick procedure, and I'm writing up a consult note, and I'm like, okay, do you have any past family history of cancer? Or you have to get their family history. You have to hit all the stuff, or else you can't bill as higher. So at high. So basically, to get whatever more money, you have to make sure that you incorporate all these elements that are just sometimes a pain in the butt.
Yeah. Oh yeah. You're like, why am I don't care. Like, let me be real with you, computer. I don't care. Like, yeah.
Well, even for a lumbar puncture, I've done consult notes. And I'm like, it's literally, I'm numbing you up and putting a small needle in there. Like, wait.
Yeah. Yeah. I know. That's like ours. When people come in, they're like, I have a UTI. I'm like, well, I'm going to have to ask you about your skin moles. So please bear with me. Like, we have to bill this appropriately.
Patients
Okay.
don't understand. They're like, why are you looking at this? Why do you think it?
Uh-huh. Yeah. I'm like, that's very nice about your UTI, but like, can I discuss your colonoscopy with you? You need to have one. They're like, this is not a good time,
Like, you
but
know,
I have to check
I
off.
haven't had a colonoscopy.
Exactly. Like the computer tells me I need to ask you this. So please just go with me.
At least you have prompts. I remember my clinical I never worked primary care as an NP, so it's just my clinical that to base off of. And yeah,
Oh my
I
gosh.
can
Yeah.
imagine
And it
a
would
lot.
come up, yeah, at the worst time. The patient's telling you some sob story and you're like, shingles vaccine. Yes, no, later. Okay, okay, yes, please. Here's the tissues. Back to it. Like you're like, hey, this is the worst. What let me think of what else. Let me check my list and see. People sent me a beautiful list of what we were going to ask. We talked about scope of practice, how you got into it. It varies by state, work-life balance. Oh, how is your work-life balance?
I mean, I'm there longer than I would love to be, so I'll get
Mm-hmm.
there at probably around 7 or a little bit before. And a lot of times, sometimes not all the time, I won't leave till 5, 5:30, sometimes closer to 6. And if you're doing that multiple times a week, it gets frustrating. Like I don't have kids
Mm-hmm.
yet, but if I did, that'd be
Yeah.
even more. Uh,
Yeah.
we are getting a second PA that's getting added to our practice in a few months. So I
Oh,
think once
cool.
they start and we get them trained in a couple months, I think scheduling won't be a problem. But
Sweet.
it's only me. I'm the one doing consults, rounding, and obviously helping, the doctor with his procedures or getting patients.
Yeah.
It just
That's a
ends
lot.
one day.
Yeah.
But no weekends, no holidays.
Yeah. Which is very nice. Do you run into situations a lot where you're like unexpectedly held over? Just because a lot of people like do wonder that with kids, like how often does something weird come up and you're like, oh, like now I can't leave, like I'm kind of stuck here. How often do you think that happens?
I think that when we have emergency cases, like for example, a GI bleed that they've been sitting on all day, decided at
Yeah.
3:30 p.m., oh, hemoglobin is 5, and we couldn't see anything with the scope, and now you guys need to do like an embolization.
Here you are.
By the way, there's sedation, so try to find a family member that'll sign off on it.
Oh my gosh.
Only emergency cases, I'll help out and make sure we get our stuff together. I obviously don't have to stay for the case or do the case, so I'll bounce after that.
Yeah. Okay. So then it kind of would still go, and the responsibilities are ultimately on the radiologist to kind of pull that together. Um, I forgot, I was going to ask when we were talking about charting, how much of your day is charting versus actual patient care?
I think probably most is patient care. The
Oh,
good thing
that's really nice.
The
Yeah.
good thing about consults is we're not internal medicine, we're not primary care. We don't have to list their 12 different like diagnoses along with what you do for them. It's like they came in with an abscess secondary to diverticulitis. So here we go, that's one. And then I'll
Yeah.
put leukocytosis secondary
Yeah.
number one
Yeah.
down. They're on IV antibiotics. Their ID is following, whatever. So it's a lot shorter, the consult notes. It's not as much.
Hmm.
We do dictate our cases, but we have templates, so that takes me like 30 seconds maybe to dictate a case.
Oh my
So
gosh.
progress
That's
note,
beautiful.
progress note, if I'm following up on a drain. Patient has pleural effusion related to empyema, status post drain placement this day. How does the fluid output look? How much was it? Did the culture show anything? What do we do for drain care? Recommend follow up in whatever time. So it's pretty targeted. It's pretty short.
That's nice. That sounds lovely. You're not including like patient reports. Her favorite thing to eat is peanut butter and jelly, and her favorite brand of peanut butter
Please see
is
API for patient's favorite food.
exactly. I think that's pretty much that hit all the big questions that I think I had. And this was incredibly helpful. Thank you so much for coming on here. Is there anything else that you would just like the world to know about interventional radiology, being an IRNP? anything like that?
I think it's probably one of the most rewarding jobs you can have as an NP. It's really fun. You get to see a lot of cool stuff, and it's not well known. I don't think a lot of
Mm-mm.
people know what we do or what we are, or sometimes that we even exist.
I
So
know.
it is
I feel like
neat.
I hit the jackpot when you emailed me. I was like, I've never even heard of this. Yes.
Oh, she's primary care, so hopefully she cares about this. This is
Oh, I
totally
cared a lot. I was like, yes.
a good thing. Is even though we're not managing patients like internal medicine would, so if that's really what you want to do, and you're like, oh, I want to titrate blood pressure meds and stuff, this is not the job for you. But the good thing is that we do procedures that involve like all sorts of organs, all sorts of body parts. So really, we're looking at different systems every day. We're looking at GYN, uh, GI, nephrology patients. We're looking at pulmonary patients. So you get to see a lot of anatomy, pathology, physiology, all that stuff. It's just
Yeah.
incorporated in a different way.
And it sounds like that would make it super easy to then go out of it. You know, how sometimes you can kind of get yourself down a rabbit hole and you're like, oh, now I'm like really good at, I don't know, some weird random thing.
Perfect thing.
Feet. Yeah. But now, yeah.
Scared about that. If I like
Yeah.
5 years down the line, if I want to do something like,
Uh-huh.
I don't know if I would ever do primary care, but maybe I would do like a specialty like cardiology.
Mm-hmm. Yeah.
But still, I'm like, ooh, I don't remember the drugs. Or
Yeah. I mean, I feel like you could learn that. And at least you kind of like are experienced with it all now, which is like super cool. That's kind of, I know, a big draw of primary care. But the thing that I'm drooling over is your charting situation.
yeah,
I think
most
that's a huge thing to keep in mind. Yeah. I'm like, what?
care about primary care taking their whole like their work home on the weekends and doing hours of charting, and I don't do that. Like if I don't finish something by 5 p.m., 5:30, like it'll be there tomorrow. I'll do it.
Yeah. Yeah. That's a whole different mess. All right. Well, this was super duper helpful. I super appreciate you taking the time to chat with us. You gave us the name of that guy on Instagram that I'm
He,
going to leave linked down below.
he's on Instagram. He's on YouTube. He makes YouTube videos.
Oh, YouTube. Perfect. We'll link his YouTube down below. Any other resources that if people were interested in IR that you think would be helpful to check out?
Ah, you know what? I'll have to get back to you if I can think of something. I don't think there's anything really available like, oh, this is IR. This is you kind of. I've been going off of books like IR books, or like I said, I had bought books based on different imaging modalities, ultrasound, CT, radiology fundamentals, X-ray, and kind of learning that way. There are radiology notebooks, like pocket notebooks, that go over the
Mm-hmm.
procedures and different things that you need to do for them. But I don't know that there's
So,
like a really good.
so it sounds like to me that you need to start an Instagram or a TikTok is really what I'm hearing.
Yeah, yeah. I'm gonna condense everything into 15 seconds and do like a funny dance.
Perfect. We're going to talk to you in a year and you're going to be like world famous for interventional radiology fun facts
I
and
can
dancing.
put them all together. And
That's perfect. All right. Well, this was super duper helpful. Again, thank you so much for coming on and talking with me about it. And if you guys if you work in an interesting specialty or really just any specialty, since we've only had one, contact me down below. I'll leave my email and we can do more of these and just talk about different facets of healthcare. It doesn't have to be nursing or NP related. Just to open your eye, like just to learn about different things. Cause I know when I was first starting in nursing school, like I didn't know respiratory therapists exist. You know, my world was just like, you are a nurse or you are a doctor. And like, I think there's a lot of really interesting other things out there. So feel free to email me if you would like to be my second guinea pig or my third or my fourth. And yeah, if you have any other questions about IR or you've worked in IR, for sure leave that info down in the comments too, because we learn a ton from you most of the time. Obviously, I know nothing about this. So that would be appreciated. All right, friends, I will see you next time. Bye.
Bye.